All right, so this is another case of wide complex tachycardia. I'm sure there'll be a lot of these, and these cases are to highlight, facts we'll talk about a lot, which I think are important to know as an emergency room physician. On the last case, I put this number up there as an exercise to help you think. Here's the answer. Like they're in alphabetical order, like eight. Yeah. So it's just a case of, how to think around corners and like approach things from a different perspective. Because remember, my opinion is being a doctor is not about what you know, it's about how you think. Because anyone can have access to the same information that we have. You just can get it on your phone. I mean, it's what you do with that information that's important. Here's the next exercise if you want it. Here's a riddle. This is an old riddle. I might have asked you this before. Again, try not to Google it or ask someone else. Like, just let it work in your mind till you can figure it out. And the riddle is, the rich want it, the poor have it. It is greater than God, and if you eat it, you'll die. So let that work around in your brain a little bit. This case is an older case. I had it with Dr. Sam Genshin. There's his amazing picture. Look at him in his fancy suit. So fancy. He was one of the residents at Monroe. He's now in Emory doing his critical care fellowship. Smart guy, good guy, great physician. Here's the case that we had. A 60-year-old female with a history of coronary artery disease, hypertension, hyperlipidemia. She comes in with bilateral arm squeezing pain and heaviness as well as shortness of breath. When she got up to walk just prior to arrival, states this felled, sweet, like her prior heart attack. She called EMS. EMS noted some hyperacute T waves. Good for you guys. On the EKG, and states they found her to be incredibly diaphoretic and hypertensive if the patient was given aspirin and nitro. Okay. Once again, the value of any EKG depends on your pretest probability. This history is how we get our pretest probability. Very high pretest probability. Many things are concerning on here. Okay, number one, history of coronary artery disease. Number two, bilateral arms. Okay. I haven't read up the literature and I don't have a lot of examples for you, but in my personal experience, anytime someone has bilateral arm radiation, I mean, they always end up needing a stent at some point in their stay in the hospital. Like, it's the same thing with AVL. When you see AVL inversion in the EKG, a huge red flag should go up. When a patient tells you bilateral arm radiation, again, a huge red flag should go up. Like, you should pay attention to what they say, look into their history, and think about serial EKGs, like an EKG every 10 to 15 minutes. Other thing is diaphoresis, okay? You can't fake diaphoresis. I always say if your patient sweats, you should sweat, okay? So this history, red flag should be going off everywhere. You should be like, oh, shoot, I really need to look into this. Let's see what's going on, okay? So we have no old EKGs, but this is the EKG that EMS has. Same thing as usual, pause, write down your findings, and think about what your interpretation is. All right, here's my overall interpretation. So number one, normal sinus rhythm. Number two, normal axis. Number three, normal intervals. Number four, the main thing on here is ST wave abnormalities, okay? The first thing that draws my eye is the precordial leads, okay? Number one, we have an upright T wave in V1. And from previous videos, we know that's not necessarily a normal sign. Is it larger than the T wave in V6? Well, not really. Okay, the T wave in V6 here is 1, 2, 3, 4 boxes. This one's only 1, 2, 3 boxes. Okay, so it's not taller than V6, but it is upright, which is concerning. And also note this linearity of the ST segment. Like, this ST segment here is very linear. And if we were to compare the length of this linearity to the amplitude of the QRS, it's definitely over half the size. We have similar findings in V2. Okay, number one, we do have J-point deviation. When we compare the J-point to the PR segment, we see about 2, maybe 2.5 millimeters of ST elevation. When we go down to V3, we see maybe a half of a millimeter. Okay, so this does not qualify for an ST elevation infarct. She's a female. She's over the age of 40. She has to have more than two and two contiguous, which we don't have. Again, pay attention to the hyperacuteness of this T wave, okay? It's not very narrow, but the amplitude of the T wave compared to the amplitude of the QRS is very concerning. Like the amplitude of this T wave is definitely over half the size of this QRS. And here in V3, if we were to cut out this QRS, we could fit this entire thing underneath this T wave. That's very concerning. Same findings over here in V4, 5, and V6. Again, we note this hyperacute T wave, this entire QRS can fit underneath here. We do have some J-point deviation, about 1 millimeter of J-point elevation compared to the PR segment in V4. Same thing in V5 with the hyperacute T wave. If you'll also notice, I brought this up before, there is some focal spotic sign, like starting maybe in V2, but extending out here to V4, 5, and V6. You can see it best in V4, is this downsloping of the isoelectric point. Again, non-specific, but these are all focal repolarization abnormalities. And again, this EKG highlights why I think you should always compare the J point to the PR segment and not the TP. Like here, like we talked about, this TP segment is downsloping. If we were to use this TP segment as our isoelectric point, when we extrapolate and follow it out, like it still runs through the J point, like there's no real J point deviation. But there is when we compare to the PR segment. Another thing to note is the development of focal Q waves. We have Q waves in V2, V3, V4, 5, and 6. Again, non-specific Q waves can be normal, but again, my thing is STEMI is not necessarily how we should think. We should think about symptoms, risk factors, and focal repolarization abnormalities, like we have in this case, right? Other repolarization abnormalities to note, again, which are non-specific but concerning in this case. Again, here in AVL, it's very slight, but there is slight inversion/depression, like it's maybe a 0.5 millimeter below the PR segment. And again, look at the linearity. Like the straightening of this segment is over half the amplitude of the QRS. And we see the same thing here in lead 1. Like it's not really that linear, but the initial deflection of this ST segment is downsloping. Like I don't have the literature on me for this case, but it does confirm that horizontal and or downsloping ST segments are concerning. And again, here in lead 3, there's not real much J-point deviation, but again, look at the linearity of this ST segment. Like look how straight that is, also compared to the amplitude of the QRS. So this was the EKG that EMS has. My overall interpretation is, well, it's non-diagnostic. There are focal, non-specific repolarization abnormalities, but in the setting of the pretest probability, the patient's history, symptoms, and risk factors, highly concerning that there's an occlusion in the coronary arteries. So Sam meets the patient at the door. As EMS is moving her over to the cot, this happens on the EKG, okay? So same thing, pause, look at the abnormalities, and then think about your interpretation. All right, so here's what I see. Okay, number 1, totally irregular rhythm, okay? And definitely we have this polymorphic ventricular tachycardic appearance. Interestingly enough, we have one single beat right here, and we have here what looks like the R on T phenomenon, where the T wave is still repolarizing and then the ventricle fires. Things to note is, again, I've talked about before in previous cases, EKG findings that help you delineate ventricular tachycardia from other abnormalities. And again, it doesn't matter. The main question is, are they stable or unstable? If they're unstable, you use electricity. If they're stable, you can think about medications. So Sam, they did chest compressions right away, and they shocked her, and she went right back into normal sinus rhythm. But again, let's go over more EKG findings. We have this waving-like appearance, okay, that looks almost like torsades. If we look closely in here, there's many fusion beats, okay? We have this wide complex tachycardia, but we have these other beats that are almost a fusion between the native narrow beat and this wide ventricular beat. There might, if we look closely, there might be some capture beats in here. And a capture beat is when you have a normal beat hiding in there somewhere. There might be one in here, hard to tell. But again, you can go down all of those EKG pathways if you want, but the short of the story is, are they stable or unstable? Sam knew she was unstable, so he shocked her. So the question is, well, is this torsades, right? Like, it looks like torsades. It looks like it's, a winding path like torsades, and we have this R on T phenomenon. But Sam knew that it wasn't torsades because he knew the QT was not prolonged, okay? This was the EKG just minutes before she went into this rhythm. Again, the numbers aren't on here. I cut them off on purpose. But a good rule of thumb is the T wave should not lie halfway between each R wave. Here's 1R, here's 1R, here's the midway point, and the QT is not prolonged. So Sam knew that this wasn't torsades. He knew that it was polymorphic ventricular tachycardia with a normal QT, and he knew that the most common cause of that was acute coronary syndrome. Here she is after the cardioversion. Again, multiple abnormalities on here. The abnormalities in the precordial leads have gotten worse. Okay, now we have over 2.5 millimeters of J-point deviation here and here, as well as here. And again, this qualifies for an infarct. And again, we note even more visible here is this Spodek sign appearance. And again, even more reason why to always compare the J-point to the PR segment. Because if we use this as our isoelectric point and we extrapolate it out, it goes through the J-point. Technically, there's no J-point deviation from the TP segment. Also, now we have some inversion in AVL. Remember, every time you see inversion in AVL, huge red flag should go up. So Sam knew all this stuff. He knew it wasn't torsades. He knew it was ACS. He knew the best way to treat an unstable rhythm was electricity. And he knew the best way to treat this rhythm is to treat the ACS, okay? Don't screw around with medications and consults, get him to the cath lab. So Sam sent her right to the cath lab, and here's the cath. Multivessel atherosclerotic disease, normal left main, 99 subocclusion of the proximal to mid LAD. Patient did well. She got a stent and went home and did just fine. And again, I'm going to bring up this pathway again because this highlights what I'm talking about. The wide complex tachycardia. The main things is got to make sure they're over 130 and the duration's less than 200, because if they're not, that's AIVR and that's a different treatment pathway. Like Sam knew, he knew it was polymorphic VTAC with a normal QTC, and he knew the underlying treatment was ACS, and the key thing is to treat the ACS. Okay, yes, amiodarone is the best medication treatment to treat that rhythm, but remember, what's the underlying rhythm coming from? Remember, being a physician is not about what you know, it's about how you think. And this is a great case to highlight the proper way to think. That's all I got for this case. Again, any questions, ask me in person. Peace, I'm out.